Thank you to our Tri-Department senior leadership for their welcoming remarks. We are ready to dive in with our first presentation, Expanding Healthcare Options with Health Reimbursement Arrangements, moderated by David Molaski, Health Insurance Specialist at CCIIO. Please join me in welcoming David to the stage.
Hi, everyone, and thank you for being here. Please join me in welcoming my colleagues here on the panel. We have Lindsay Murtaugh, who's the Director of the Market-Wide Regulation Division at CMS within CCIIO. We also have Bonnie Norton, who's a Director of Marketplace Eligibility Support at CMS within CCIIO. We're also joined by Matt Litton, who's a Senior Employee Benefits Law Specialist at the Department of Labor, and also Kevin Knopf, who's a Senior Technician Reviewer with the Health and Welfare Branch in the IRS's Office of Chief Counsel. Our policy experts here will start with a presentation on the new health reimbursement arrangements, providing some background information on the final rule and what it means for employers and how we anticipate some of the provisions will operate. After that, we'll open it up for questions, and you'll be able to address your HRA questions to the policy experts here at the microphone here in the center. You can also submit your question virtually to HRA@cms.hhs.gov during the presentation, and Gina will assist us in reading those out loud. So I think, Kevin, you're going to start us off, correct?
Actually, I think Matt.
Oh, okay. Matt, go ahead.
Yeah. Thanks, David. So we're very excited to be here today, and hopefully we'll be able to answer all of your great questions. We're going to try and move a little bit quickly. I know we started a little bit late, so we want to make sure that we have plenty of time for Q&A. So as I think has been mentioned several times today, a lot of our work for the past couple of years has been driven by the President's executive orders. And in October of 2017, the President issued an executive order to promote choice and competition in healthcare markets. Now this executive order directed the Departments of Labor, HHS, and Treasury to take certain actions to expand access to alternative types of health plans, including health reimbursement arrangements, which is, of course, what we're here to talk about today. We know that many employers would like to be able to help their workers and their families by giving them tax-preferred funds to pay for health coverage, even if they aren't able to offer a traditional group health plan. HRAs are a way of permitting employers to do just that, so they can focus their time on running their business rather than administering health benefits. As part of our rulemaking process, economists from the Treasury Department conducted an impact analysis, and we're very excited about the results. We expect that roughly 800,000 employers will provide HRAs used to pay for individual health insurance coverage to more than 11 million employees by 2029, once these rules are finally phased in. We also expect that the number of insured persons will increase by about 800,000 by 2029 due to the final rules. So with that, I'm going to turn this over to my colleague, Kevin Knopf, and he's going to give us a little bit of background on HRAs and then the final rules for individual coverage HRAs in particular.
Okay, HRAs were created in 2002 by administrative guidance. This was Notice 2002-44 and Revenue Ruling 2002-41. The gist of this administrative guidance were three things. HRAs cannot be funded by employee contributions. You can carry over unused amounts, and they can only be used for medical expenses. That is, no cash outs. At the time, there were some people who were creating vehicles that were saying, and if you don't use the money for health, you can get it in cash. We wanted to put a stop to that. That was sort of the driver for that HRA guidance. So nonetheless, so they can only be used for medical expenses, but those reimbursements of medical expenses are non-taxable. Typically, HRAs are defined as a promise to reimburse a set amount per period, usually a year. This results in an annual limit on whatever's being reimbursed. So if what is being reimbursed includes essential health benefits, an HRA that covers essential health benefits has an annual dollar limit on essential health benefits, which is a problem for the prohibition on annual dollar limits for essential health benefits under Section 2711 of the Public Health Service Act. It's also a problem that once you spend all the money in the HRA, you no longer have any coverage for preventive care, which is another requirement for HRAs, because HRAs, they are group health plans subject to all the requirements for group health plans. So now, prior guidance allowed combining or integrating HRAs with other group health plans, as well as Medicare B, D, and TRICARE, to satisfy the requirements, but they didn't allow combining with individual health policies. The 21st Century Cures Act created qualified small employer HRAs, or CUSERA. These were available for small employers, in particular ones that weren't applicable to large employers, and they allowed them to use HRAs for individual premiums. Guidance on CUSERAs was in Notice 2017-67. So then, moving on. On June 14th, 2019, the departments finalized regulations that had been proposed in October 2018. The final regulations covered the following. You had rules for HRAs being integrated with individual health policies, also called individual coverage HRAs, or the non-preferred term ICHRA. Rules for PTC eligibility for someone who's offered an individual coverage HRA. Rules for accepted benefit HRAs, which are different from the existing HRAs, which were only used for accepted benefits. And then two provisions that other people will have to talk about: the special enrollment periods for individuals offered CUSERAs or ICHRAs, and the non-application of ERISA to individual policies purchased with funds from an individual coverage HRA or a CUSERA. So there are 6 basic requirements for an individual coverage HRA. Individuals with the individual coverage HRA must have individual insurance coverage or Medicare. Medicare was added since the regulation was originally proposed. You cannot offer an employee a choice between a traditional group health plan and an individual coverage HRA. You can divide your employees into specified classes and offer a traditional group health plan to one or more classes and the individual coverage HRA to other classes, but no individual employee can be given a choice between a traditional group health plan and the individual coverage HRA. All employees in a class who are offered an individual coverage HRA must get that individual coverage HRA on the same terms. Generally, that means the same dollar amount, among other things. However, you are allowed to vary the dollar amount by age, up to a 1-to-3 ratio, and by family size. Employees must be allowed to opt out of the individual coverage HRA at least annually or at termination. This is to prevent employers sort of offering employees a very low dollar individual coverage HRA, which wouldn't really provide affordable coverage, and keeping them out of getting a PTC. Unlike a CUSERA, any amount in individual coverage HRA will disqualify an employee from a premium tax credit if they take it, versus a dollar for dollar reduction, which is what would happen with a CUSERA. You have to substantiate that the employee and anyone else covered by the HRA has the individual health coverage, both before and during coverage by the HRA. And you have to provide a written notice, generally 90 days before the plan year. And we provided a model notice as well as model attestation. Moving on the slides. Yeah. I mentioned classes of employees. While the regulations allow you to separate the workforce into classes in deciding whom you offer the individual coverage HRA, the regulations limit your ability to divide your workforce into classes. The allowed classes are: you can have full-time and part-time. For this purpose, you can use the standards under the employer shared responsibility provisions of Section 4980H, which is like a 30 hours per week as full-time, or you can use the 105H definitions. You can choose which one you want. If you're a small employer not subject to 4980H, you might want to use the 105H ones instead. You can divide employees between salaried and non-salaried. You can divide employees by the rating area of the employee's work site. For example, if you have workers in 2 cities that are 2 different rating areas, you could offer the workers in each city a different individual coverage HRA. You can have seasonal employees as a class. Again, you can use the standards under 4980H or under 105H. These are the Internal Revenue Code. You can have employees under collectively bargained agreements as a separate class, including employees covered under a related participation agreement. For this purpose, each agreement can be a separate class. It's not like all my collective bargain employees are one class who gets one individual coverage HRA. We recognize that different unions may want different benefits, so you could have a different choice for each, a different class for each separate union. You can have employees who haven't satisfied a waiting period. You can have certain foreign workers as a class. You can have the temporary employees working through a staffing firm, and then you can combine all these different classes. For example, you could have a salaried full-time employees who satisfy the waiting period and hourly full-time employees who satisfy the waiting period as two separate classes, one getting a group health plan, one getting an individual coverage HRA, or both of them getting individual coverage HRAs with different amounts. In addition to restricting the type of classes, the final regulations include a minimum class size rule. The minimum class size rule only applies in certain situations. In particular, it only is an issue if you're offering both the traditional group health plan and the individual coverage HRA. So if you're a very small employer, less than the minimum class size, you can offer an HRA, you just can't offer an individual coverage HRA to some employees and a traditional group health plan to others. The minimum class size is also not an issue for classes not offered coverage. So if you're not offering your part-time employees coverage at all, and they're less than the minimum class size, that's not an issue that they're less than the minimum class size because you're not offering them coverage. For this purpose, minimum class size, if you have less than 100 employees, the minimum class size is 10. From 100 employees to 200 employees, the minimum class size is 10%. If you have 200 or more employees, the minimum class size is 20. Class sizes are based on a reasonable expectation of employees on the first day of the plan year. Actual size of the class is based on the number of employees offered as of the first day. So you may offer it to 50 employees, but only 10 decide to elect it. That doesn't mean that you haven't satisfied the minimum class size rule. And that also, because you're doing it at the beginning of the year, mid-year changes in class size or employer size have no effect on the current year. Finally, only certain classes trigger this rule. The salaried, non-salaried class, full, part-time, primary worksite rating area. With respect to the primary worksite rating area, only where the geographic area is less than a state. So if you have a bunch of employees in one state and 5 employees in another state, you can treat those 5 employees as a separate class, even though that's less than the minimum class size, because it's a different rating area, different state. We also have a new hire rule, which allows you to phase in for employees hired after a certain date. You can subdivide other classes into existing employees and new hires, and the minimum class size doesn't apply to the new hires. You can have different dates for different classes. There are a lot of details and other details, so we highly recommend reading the reg with a preamble to get everything.
Thanks, Kevin. And we know that there might be scenarios where an employer wants to offer an HRA that is not integrated with other coverage. For example, some employers may want to offer an HRA without regard to whether their employees have other coverage at all. That's why the final rules further expand HRAs by creating a new type of more limited HRA, which is an accepted benefit HRA. These are exempt from the requirements of Chapter 100 of the Code, Part 7 of ERISA, and Title 27 of the Public Health Service Act. I think Kevin touched on this earlier, but I want to point out here that an accepted benefit HRA is different than an HRA that only provides reimbursements for other types of accepted benefits, such as limited scope dental and vision coverage. An HRA that can only be used to reimburse accepted benefits is not subject to the rules we're talking about today. In contrast, accepted benefit HRAs are subject to the final rules, but they can be used to reimburse a broader range of expenses. Now, to qualify as an accepted benefit HRA, the first requirement is that the HRA has to be limited in amount. So for this year, that is an $1,800 cap. However, that number is indexed for inflation, so it will rise from year to year. Carryover amounts are disregarded for purposes of this rule. However, there is an aggregation rule, so you can't just cobble together a bunch of different $1,800 HRAs and say that they're all accepted benefits. Those numbers would have a cumulative effect. The next requirement is that an accepted benefit HRA can only be offered to employees that are also offered a traditional group health plan. However, the employee is not required to actually enroll in the traditional group health plan in order to be eligible to participate in the accepted benefit HRA. The next requirement is that the accepted benefit HRA must be available under the same terms to all similarly situated individuals, regardless of any health factor. And the intent of this provision was to prevent an accepted benefit HRA from steering participants or dependents with adverse health factors away from a sponsor's traditional group health plan. And then the next requirement is a prohibition on reimbursement of certain types of health insurance premiums. So an HRA, or an accepted benefit HRA, cannot be used to reimburse premiums for individual health insurance coverage, traditional group health plan, or Medicare. If you want to do that, you've got to comply with the other integration rules. However, accepted benefit HRAs can reimburse premiums for other accepted benefits, such as dental and vision coverage, also continuation coverage, and then also short-term limited duration insurance, except for in very special circumstances that don't apply in any states yet. But if HHS were to make a finding that accepted benefit HRAs being used to reimburse short-term insurance premiums is having a negative impact on the small group market, HHS has the authority to limit small employers with fully insured plans and even partially insured plans from being able to provide those types of reimbursements. And then the last requirement for accepted benefit HRAs is just a notice requirement. So for private sector employment-based plans, long-standing notice requirements under ERISA already apply. For these types of plans, the final rule cross-references ERISA's Part 1 disclosure requirements. And then HHS has announced that they will be imposing a similar requirement for non-federal governmental plans in future rulemaking. The final rules for individual coverage HRAs also include a special DOL-only provision that amends the definition of employee welfare benefit plan for purposes of ERISA. DOL's objective here was to provide assurance to stakeholders that insurance policies that are sold in the individual market are actually going to be treated as individual health insurance coverage and not part of a ERISA-covered group health plan, which would make them subject to group market rules, which are mutually exclusive from individual market rules in a variety of ways. At the same time, we recognize that trying to draw a bright line rule for when a particular type of coverage or financial product might become part of an ERISA plan is really sort of beyond the scope of this rulemaking. So the criteria in this safe harbor that we've issued under the definition of a welfare plan it's very narrow, and it really only addresses individual health insurance coverage that's being paid for with the help of an HRA, a CCIIO, or a supplemental salary reduction arrangement. Can you go to the next slide? The safe harbor includes 5 criteria. So the first is that the purchase of any individual health insurance coverage has to be completely voluntary for employees. The second is that an employer, employee organization, or other plan sponsor cannot select or endorse any particular issuer or coverage option. Of the 5 criteria, this is probably the one that we've gotten the most questions about. And the principle that we've sort of tried to articulate is that an employer can help employees shop for individual health insurance coverage. We know that they're going to want to do that. But what they need to do is to provide assistance in a way that's totally unbiased, neutral, and uniformly available. And they cannot steer any participants or beneficiaries towards a particular issuer or coverage option in any way. The next criteria is that reimbursement for non-group health insurance premiums has to be limited to solely individual health insurance coverage. As I said, this is a very narrow safe harbor, and it does not address any other types of coverage that might be paid for with employer funds. The fourth criteria is that an employer, employee organization, or other plan sponsor receives no consideration in the form of cash or otherwise in connection with the employee's selection or renewal of any individual health insurance coverage option. And the fifth and final criteria is a notice requirement. And so each plan participant has to be notified annually that the individual health insurance coverage is not subject to ERISA. For individual coverage HRAs, this notice should be included in the more comprehensive notice that Kevin discussed earlier. And for CCIIOs, the notice can be included in other required disclosures, for example, the summary plan description. And with that, I'll turn it back to Kevin, who's going to talk a little bit about premium tax credits.
So the question comes up, if you're an employee who's offered an individual coverage HRA, how do you determine whether it's affordable and minimum value for purposes of can you get the PTC, or are you disqualified or subject to the firewall due to the offer of the individual coverage HRA? If it's affordable, it's going to be treated as providing minimum value. If the individual coverage HRA is at a level that it's considered affordable, it's automatically considered minimum value. And then the question is it affordable to do that? You look at the lowest cost silver plan based on the residence of the employee. And so you take the lowest cost silver plan, you subtract the amount, the monthly premium for the lowest cost silver plan based on the residence, you subtract the amount of the individual coverage HRA for that month, and the amount that's left, is that greater than the percentage, which is around 10% of the individual's household income. We've issued proposed regulations with respect to 4980H. For those purposes, the employer would be allowed to use as a safe harbor the rating area where the employee is working as opposed to the residence. Again, lowest cost silver plan based on the rating area of the employee's work location, and then you subtract the individual coverage HRA amount and whether that premium is greater than the percentage of the individual's household income. And for those purposes, we've also issued proposed regulations allowing people to use the existing W-2 safe harbor, rate of pay safe harbor, and federal poverty level safe harbor.
Great. And then the final piece of the rule is designed to address the fact that individual coverage is on a calendar year basis. And we recognize that a lot of employers may currently be offering coverage that is not on a calendar basis. So if they want to offer an individual coverage HRA to their employees, those employees are going to need to have a way to get individual coverage off of the calendar year. I will note that if you are considering this, it may be easier down the line to kind of align with the calendar year, but we wanted to make sure that there was a way that individuals could get individual coverage that is required under the rules. And so we issued a rule as part of this package that provides a special enrollment period for individuals who newly gain access to an individual coverage HRA or who are provided a QCERA. And that special enrollment period is available either on or off exchange and would allow them to get in the middle of the year or at the beginning of the year, but it is subject, as Bonnie's going to talk about, to verification. So even though they would be eligible if you have a calendar year HRA to get it to use that SCP, it's likely that they'd rather just go through open enrollment if the timing works.
Thanks, Lindsay. So I'm going to talk a little bit about what we are doing to implement aspects of the rule for the FFE. So we are doing a variety of things to support employers who are interested potentially in offering an ICHRA or a QCERA. We have a website that provides information on ICHRAs, QCERAs, and small group coverage so that employers could compare the different options that they have and what may work best for them. We also have information for folks who want to actually get started offering an ICHRA or QCERA. And one of those things is a tool, an employer HRA affordability tool that makes it easy for employers to look up the lowest cost silver plan. We did have plan information already available publicly, but this sort of makes it very easy for employers to look up just the information that they need for offering the ICHRA, which is the lowest cost silver plan. We also have a variety of tools and information to support employees who have HRA offers. We have a website, again, that provides all of the information that they need to learn about their HRA offer, be it a QCERA or an ICHRA, and helping them to differentiate between them. We also have a tool available for employees that is an affordability worksheet that allows employees to calculate before they go through the application or get started with the process whether or not what has been offered by their employer is affordable for purposes of APTC, as you just heard a little bit about. So if the ICHRA or QSERA is not affordable, they may be eligible for reduced or no APTC, and we want to make sure that folks are aware of that and get enrolled correctly. So right now we have a worksheet available, a PDF worksheet that's downloadable, and that folks can use before going through any applications or purchasing a plan on or off the exchange, where they enter in some information about their household and about their HRA offer, and they get a little determination spit back out of them that says whether or not it might be affordable and what that might mean for their eligibility for APTC, so that folks can make the right choice for them for their coverage. We're also building additional functionality to make the whole process a little bit more seamless for employees, and that means that we're building all of that functionality into our application as well. So employees will be able to go into the application, put their HRA offer information in, and have that APTC eligibility calculated as they go through that process. So there will be a calculation of HRA affordability, and then subsequently what that means for their APTC. It will be enfolded into all of the application, noticing, et cetera. For the SEP that Lindsay just talked briefly about, right now employees can access that SEP by calling our call center. We wanted to make sure that folks could get in through the special enrollment period right away. It's important for people who have HRA offers that might be off calendar year, but also new employees who might be joining at a different time than other employees, even if it is a calendar year plan. And we wanted to make sure that everybody could get in and use their HRA and access coverage through the FFE. And so that's available now, but will also be built into the application, so that will also be a seamless experience for employees when they come in and complete the application. They can attest to the HRA offer and be able to enroll through the special enrollment period outside of open enrollment. Finally, FFE data availability. We recognize that it's really important for folks to have access to plan information so that they can make the right choices about the kind of coverage that they want to offer to their employees based on what might be available for employees to purchase. And so we do have a variety of data files that are available now. And we're going to try to continue to make more data available, but we have our rate review data, which includes plan information for both on the exchange and off of the exchange, and we have our landscape and PUF files that have a lot more information on our on-exchange plans, all of the details about those, so that folks can download that information and use it however they might want in order to help make their decisions.
Please join me in thanking our panel here. And we'd like to open up the floor for questions. And if you have a question, two ways you can ask it. You can either approach the microphone that we have set up here. And when you're asking a question, please identify yourself by your name and the organization that you represent. Or if you prefer, you can submit your question electronically to hra@cms.hhs.gov. So if anyone would like to approach the microphone.
I'm in. It's a short microphone. I'm Jack Hooper from Take Command Health. I just want to thank you all so much for your work on all the rules and the tools to actually make it come together. Two questions. One is COBRA. And then another one is enforcement of these rules. If there's plans, how are we going to make sure that bad actors don't kind of poison the efforts that are going on here? Thanks.
You have anything more specific you want to ask about COBRA?
How does it work with an individual coverage?
Well, I think the guidance is clear just as clear about COBRA now as it was before we issued this guidance. The question I always have about COBRA and HRAs is you have to pay a premium for COBRA. So in a lot of situations, I'm not sure why someone wants to take after-tax dollars, pay a premium for COBRA, in order to now take those after-tax dollars and use them for health and health only. And the question that makes this all complicated is, well, how do you set the premium for COBRA? And I mean, I recognize that that's an area that is an opportunity for excellence for the IRS because we haven't issued guidance on it yet. In many cases, again, someone's not going to elect COBRA because they can't get anything more out than they pay for the premium. If you have someone who has been covered by an HRA, at the same time, if you have someone who's been covered by HRA for 5 or 6 years and they haven't been using all of it, it's a very generous HRA and they've been accumulating amounts, they might have a substantial balance that they want to continue to have access to. And right now we say, use reasonable methods. I assume that would mean it's not going to be more than sort of the annual accumulation amount for the premium. At the same time, I think there were people behind you, but at the same time, at some point it seems like it'd be something less than the maximum you could get out. But we recognize there isn't guidance on that, and that's something we'll continue to keep in mind. And what was your second question?
I know it's early, but just thinking about enforcement of these rules, we've seen them in action. We think they're really good, but there's obviously opportunities to skew them, and that could hurt the whole industry and the whole initiative that's kind of surrounding them. Just curious if that's a thought or if it's been discussed.
Yeah, I mean, we enforce all of our rules. So these are, HRAs are self-insured group health plans. So just as a jurisdictional issue, for private sector employers, it would be the Department of Labor that's enforcing the rules. And then for plans that are being offered by state and local governments for their employees, it would be HHS who would be enforcing those rules against those types of plans and employers.
Well, thank you all.
Good morning, I'm Jennifer Pender from Georgia. And I have not heard this question come up really, and it has to deal with premium only, because the ICHRAs are able to be pre-taxed. And my question has to deal with the discrimination with premium only plans and highly compensated employees. Because if we really take a step back, if you can offer a group health plan, normally you're going to have management or salaried people on a group health plan and potentially hourly people. And because you're able to just offer that, they don't have to take it, you're kind of setting a group up for discrimination of the premium only plan due to the highly compensated rules. And how can we address that when the offer is made of the IHRA, it's affordable, and you've got such low participation, but yet you've got your highly compensated people who may be, either taking advantage of that or are on a group health plan, and then discrimination with the Section 125.
I don't know that it's any
Am I
different.
making sense? I'm sorry.
I don't know that it's any different of a challenge than you face now, that if you're offering a traditional group health plan, that the highly compensated are able to afford it, and the non-highly compensated say, well, it's all very well that it may be, for whatever reason, we can't afford it, so we're not going to buy the coverage. I mean, you face that with a traditional, you could face it with a traditional group health plan now. And I guess you deal with it the way you deal with it now. That may mean that it's, the highly compensated don't get a pre-tax benefit. That's consequences under 105H.
My name is J.D. Cleary, and I'm with the organization People Keep. We launched our QSEHRA administration product back in 2016 after the Cures Act, and more recently, obviously, the ICHRA. I share your, not a big fan of ICHRA. But my question's around the 90-day notice requirement with the individual coverage HRA, and used the term generally a bit ago. Is there any leeway for an employer offering an individual coverage HRA for the first time to put that in place sooner than 90 days out? That's been our customer's primary challenge, is finding out about ICHRA and wanting to offer it very quickly, but having to meet the 90-day notice requirement, meaning they have to offer it 3 months from now. Is there any leeway there? Any way for a small business that finds out about ICHRA to offer it quicker than 90 days?
I don't think there's anything in the current guidance that provides an exception.
Meaning that if they find out about ICHRA on February 3rd, they won't be able to offer the actual ICHRA program until May 3rd, generally?
All I can tell you is we don't currently have an exception to that. So no.
Yeah, correct. And when we say it's generally required, the exceptions are really focused for people who are hired, you know, sometime in the middle of the year, and they don't necessarily need to get the 90-day notice for those people. It's not a general exception for newer kind of entrance into the HRA.
There is an exception granted for newly established businesses, correct? If the business just newly became formed in the last 120 days, then there is an exception for that condition, correct?
No, that rule is not a general exception for newly established businesses. I'd have to pull it up and look at it to explain exactly when it applies, but it doesn't apply just because you're a new business.
Great, thank you. I think I'll catch you on that after. Thank you.
Before we take this gentleman's question, Gina, are there anything electronically that's been asked that you'd like to?
Okay. Bonnie, this one's for you. Are there any updates from when healthcare.gov will have fully integrated the HRA functionality into the application and eligibility system?
Yes, I can say that our goal is to have that functionality integrated into the application and eligibility for the individual coverage HRAs in 2020. So that is our goal right now. We feel good about it, and so folks should be seeing that soon.
Gina, maybe I'll ask you if there's one more, and then we'll resume with this gentleman.
Sure. We just have a clarification here about, did you happen to say that it's not a class if an employer selects payout amounts by age?
No, we didn't say that. Age is not a classification. Within a class, you can vary the same terms by age on a 3-to-1 ratio, but you can't set up this group, this age is one class, this age is another class. That's not the same thing.
Thanks for the clarification.
Okay. Sarah, go with your question.
Hi, folks. I'm George Kaldropoulos with Health Sherpa. Wanted to thank everyone at CMS for this for today and for all the various initiatives that we were discussing. 2 questions keep coming up as we pitch this to our large employer clients, and they're a little sticky, and I'd appreciate a little help. So one is having to offer all plans without biasing selection, right? That can create logistical issues. In some markets, there are 14 or 15 individual market issuers. Some of them are tiny. They have maybe 2,000 clients. And they're saying, well, if we offer the 5 that we're able to integrate with and offer, is that biasing by not offering the other 10?
I don't quite understand what you're asking.
I think you're asking about the safe harbor, the prohibition on selection and endorsement?
Yes.
Okay. So I guess it depends on kind of all of the facts and circumstances. If you're specifically only going out and trying to integrate with 4 or 5, then no, you can't do that. But if you have just, let's say there's, 10 issuers in the relevant market, and only 5 of them approach the employer through a broker or whatever and say, we want to try and offer this, there's nothing that prohibits that. But to the extent that those other 5 issuers want to come in later and say, we want to get in on this action too, you have to remain open to that possibility. So you can't, sorry, go ahead.
So the intermediary, so if the technology platform has integration with 5, that's okay to say we can still offer it those 5 versus having to wait until all 15 are available, which may never happen.
Well, I think the analysis would turn on why does the platform only offer 5 options. Is it because they've excluded the other 5 options in some way, or is it because there were only 5 issuers who wanted to do business with them? As long as you're kind of open to all possibilities and accepting all issuers that want to offer their products, then I think that would be okay. But you can't take any steps to exclude anybody for any reason.
Yeah, and the clarification is usually when there's 15 issuers, 3 have 80% of the market, and then a bunch of them have 2,000 members and no IT department, so they can't really integrate.
I understand, but I mean there's going to be logistical challenges. But the whole idea of the the DOL-only safe harbor is that we're really trying to kind of delineate what's the difference between an employer who's just giving money to their employees and then an employer who is setting up a traditional group health plan and actually working with issuers and intermediaries and being involved in that whole process. The whole idea of the individual coverage HRA is that the employer should be taking a step back and not be involved in any way, and not selecting plan administrators that are going to get too involved in the selection process, and they really are just giving money to their employees, and then it's up to the employees to go find their coverage.
Thank you. If I can ask a second question real quickly. So the class restriction based on rating area, so that's specifically come up in the context of some of the larger employers who want to pilot ICHRAs. So essentially, if you've got a distribution center that you'd like to roll it out at, if you happen to have a retail location in the same rating area, you basically have to do it for both, and that really complicates things. So I guess what's the rationale behind the sort of the multiple level of class size restriction?
Well, again, all of these rules were because there were concerns of people sort of somehow pulling out high-cost individuals and putting them in the individual coverage HRA, giving everyone else a traditional group health plan. So in your situation, you're saying that they have two business-type things within the same rating area, and they only want to offer the ICHRA to one of them, and they're offering a traditional group health plan to the other one, or? Well,
they want to pilot ICHRAs and see what the reaction is from the employees and how the rollout goes and so on and so forth. So they'd like to limit that to a single distribution center. But as it so happens, in that same rating area, there are a bunch of retail locations as well, and so it suddenly becomes just organizationally challenging to roll it out across both contexts, and it sort of becomes more than just a pilot.
That's unfortunate. I don't think our current class rules provide an exception. Unless you can find a way that this group is salaried, this group is not, this group is part-time, this group is full-time. In that way, you can't sort of divide a rating area based on anything other than other classes that are allowed. And retail versus warehouse isn't one of those classes at this time.
Thank you.
Hi, Heather Foster, Association for Community Affiliated Plans. My question is a little bit of a follow-up to the enforcement question previously, and really about verification. And for example, with the traditional HRA employer coverage, we know that the employees have to enroll in ACA compliant coverage. They cannot use that to purchase short-term coverage. However, we also know that consumers are constantly enrolling in short-term coverage without realizing what they're getting and that they don't necessarily know the difference. So what sort of verification steps will you have in process to ensure that consumers are actually signing up for the ACA compliant coverage?
I'm not sure I have a... So the final rules actually require that the employers are getting verification from their employees that are enrolled in the individual coverage HRA that they're using it to buy eligible coverage.
Right, and if the employee doesn't know what they're actually signing up for, a self-attestation form really is not going to solve the issue here, because of course they might think that they've signed up for compliant coverage and so they've self-attested, but in reality they haven't. So what sort of checks do you have to make sure that you double checking the employer, that the employer is confirming that these are actually compliant plans rather than the enrollee just signing up for whatever they think?
I think it's safe to say that we're in the process of developing all the enforcement mechanisms related to individual coverage HRAs, and it's not something that we necessarily have answers to today.
So I hope that's something you will consider then.
Hi, good morning. Thank you all. I'm Amy Smith from Independence Blue Cross. I have two questions. So my first question is with regards to special enrollment periods and the ability to send within the 834 transactions an indicator that these are in fact enrollees that are eligible for an SEP because of being offered the ICHRA coverage. Is that, I did submit a help desk ticket a couple months back and was told that it is in the works to have an indicator. Just wanted to ask for an update.
Yeah, so the special enrollment period functionality is some that we're working on right now and plan to have in 2020, and when that's complete, that will be part of the functionality.
So that was the part of the integration functionality you were referencing earlier?
Exactly.
So
Yep.
this year, okay, great. And then my other question is with regards to state-based exchanges. Has there been any conversations also having to do with the integration with those entities having similar functionalities? Have they, said anything about that?
Yes, we've been talking a lot with the state-based exchanges about implementation of the HRA functionality, sort of the information that we are providing, the tools, the integrated functionality in the application, sharing with them everything that we are doing to support their own implementation. And the state-based exchanges do all have their own implementations underway to support employers and employees as well on HRA. So we are talking with them closely and providing technical assistance with relation to everything that we're doing to hopefully make it a little bit easier for them as well.
And is there anything required for SBEs or?
I mean, they have to comply with the rules just like the FFE does. So that would be what they have to do.
Okay, thank you.
Hi, good morning. I'm Tom Brady with Acero Health Technologies. I have a couple questions. One, because the ICHRA rules are based on the original HRA rules, and because employers in the past have had the opportunity to condition some amount of contributions to the HRA based on participation in healthy management programs or healthy behavior programs, is that an option for employers as well, to level on top of the ICHRA contribution structure incentives available to all employees to meet the discrimination concerns, but at the same time allow employers to continue healthy management programs in conjunction with the ICHRA? I know that's a curveball.
I think that's problematic with the same terms rules. And there are different ways to view it. One view is, well, everybody has the same opportunity to participate in this program, therefore it's available to everybody. Or you could say, but in the end, this person gets this amount and this person gets a different amount. That's not the same terms. It's not based on age.
But how would that
the
be?
same terms rules aren't, they may be sort of a proxy for non-discrimination, either health-wise or otherwise, but they're not specifically, so there's no specific exception that says, oh, you can change amounts based on a wellness program. It's not there.
Yeah, if I can just add to that for a second. So the general rules for wellness programs, they actually exist as an exception to the HIPAA non-discrimination requirements, and so that's where that comes from. But the same terms requirement for ICHRAs, that's actually a separate requirement from HIPAA non-discrimination that has its own independent effect.
Okay.
So without some corresponding exception, I don't see how you could offer a wellness program with it.
Okay. And then similarly, but a little bit different, if an employer wanted to contribute to the employee's HSA, if they purchase a qualified health plan, HSA qualified health plan, using the ICHRA, I know there's rules in the guidance related to, from an employer's perspective, that it either has to be a premium-only plan, or it has to be an ICHRA that only reimburses amounts after the deductible has been met. But could an employer contribute to an HSA in addition to the ICHRA if the employee picks a plan that's an HSA qualified plan and the employee opens an account?
If the employee, I believe if an employee is otherwise an eligible individual for an HSA, the same terms rules don't control the amount that the employer could contribute to an HSA.
So if I'm hearing that correctly, they could potentially offer X amount of dollars to employees who sign up for an HSA qualified plan, even though some employees may not use the ICHRA to purchase an HSA qualified plan.
Yes.
Okay. And then the third question, which builds on the prior question related to what an employer may or may not do relative to working with certain carriers. In the scenario that was presented earlier, if the If the employer has set up payments, for example, direct to 5 of the 15 carriers in the area because only those 5 want to support that, but an employee goes and purchases coverage through the healthcare.gov, for example, and not through the employer's vendor, I would assume that there's nothing the employer can do to prevent that employee from purchasing the coverage through healthcare.gov, nor prevent them from getting reimbursed. I'm assuming that that's part of that compliance with
Correct,
the
yeah. Reimbursement would also have to be available to that employee who's gone to the exchange.
Right, okay, thank you.
Gina, do we have one more submitted electronically?
Sure, we have a few. Very reasonable question. Will today's slides be sent to attendees? Yes, we will do that, and if you'd like to access them now, they are on the Treasury website, Labor, Aid Department's website. We'll send out a link. Let's leave it at that. We're good. Have the departments addressed the issue of the timing of individual coverage binder payments? Many carriers require individuals to make a binder payment, first month premium, at the time of shopping, which can be in November. And yet the reimbursements are not available, the reimbursement money is not available until the ICHRA plan starts in January.
We're aware of that. We're contemplating how to address it.
Okay. Thank you. Can self-employed take advantage of accepted benefits for short term? And how do you define offer coverage?
What was it? Is that self-employed people?
Mm-hmm.
And what was the rest
Who
of it?
would be offering them the accepted benefit HRA?
I think
I'm
that's
not
why
sure-
they asked how do you
I'm
define
not sure
offer
self-employed
coverage.
individuals can offer themselves an HRA period. I don't think that's available as an option to a self-employed person.
Sir?
Todd O'Pennick with Aon. I work with large employers. And my question is around the timing of premium availability and plan availability. So you mentioned the tool that you have already has 2020 rates. Most large employers plan their annual enrollment cycles way early, late summer, August, September. Many start in October. To the extent that the plan, the rates may be final, but the plans may pull out last minute, or the plans may not end up being available. What flexibility exists in the regulations for an employer that, did their planning, set their HRA subsidy rates, let's say in August, but ended up in the kind of not exactly where they expected due to the dynamics of the market later in the year?
We've issued proposed, I assume you're talking about for 4980H purposes?
Yes, for the affordability, yes.
Our proposed regulations propose that, and people can rely on them for 2020, and 6 months after we issue final regulations, plan year starting up to 6 months after we issue the final regulations. Our proposed regulations allow employers to use the lowest cost, look at the lowest cost silver plan for the January of the year before if it's a calendar year plan, the January of the current year if it's a non-calendar year plan. So for 2021, you can look at January 2020 and design your plan on the lowest cost plan for whatever area for January 2020 and rely on that even if that plan doesn't exist when you finally go into whatever.
Thank you. And a quick follow-up, but for a theoretical employee that falls in that situation where the rate was set but the plan was not available, so therefore they have nothing affordable to purchase in the market based on their current year rate as opposed to last year's rate, would that would they be eligible for premium subsidies?
Well, first of all, the individuals always look at sort of the current information and their residence, whereas employers can decide to use the employer location and the prior January. Even individuals, their eligibility for a premium tax credit is independent as to whether the employer who's using a safe harbor is protected by the safe harbor. So even if the employer using the safe harbor is considered to offer an affordable plan, if for an individual based on their residence and their facts, it is not in fact affordable, they can still get the PTC and the employer won't be subject to 4980H as a result of that if they qualify under the various safe harbors.
Thank you.
I think we have time for one more question, sir.
Thank you very much. Ryan Jessel from Willis Towers Watson. We also work with large employers, and my questions are related to the class definition and same terms requirements. A lot of our employers may have employees that work and live across state lines, and I know that the class definitions, as currently provided in the rule, allow definition of class by worksite location and not by residence. But for someone living across state lines, their premium is going to be determined based on where they live. Is there thought being put toward future rulemaking to align that, better align that with how folks' premiums are going to be set?
You know, I think that part of the reason that we did it this way is feeling that it was easier for employers to operationalize based on their own location. I think that going forward, as this rolls out, we'd be very interested in feedback about whether that is something that there's a lot of interest in, given that it would add a fair bit of complexity.
I mean, there's sort of two separate questions. I mean, for 4980H purposes, the employer can design it based on employee location. If he wants to be more generous because he has employees working in another state that need higher amounts, they could do that, but they'd have to be just as generous for all the other employees in that employee location. If the problem is that you don't want to be generous to everybody, you just want to be, you don't want to have to sort of provide a windfall or whatever to the people in the lower cost areas, that's something we'd have to adjust things for.
Well, and I think the challenge that I particularly think of, because I'm based in the Northeast, is folks that live on the Connecticut-New York borders, for example, where you've got New York, which is a community-rated state, and Connecticut being based on age. Someone who lives across the line, you're going to vastly over-subsidize one group or vastly under-subsidize, and that's where the challenge becomes. The other question I had was around dependent credits. I know right now dependent credits have to be just a flat credit regardless of the type of dependent, whether it's a spouse or a child, and also can't vary by the dependent's age. Is there thought being put into realigning that also with how the dependent's premium would be set in the individual market?
I think that's another area where we have gotten feedback that is an area that people may want to see some change. Again, that's an area where we felt that it was important to try to balance simplicity of the rules to make it so that employers can access this in a very simple way, as Carol was talking about, if they want to. So that's another area where, as folks continue to have experience with these rules, we'd love to hear feedback. At this time, I think it's fair to say that we're not actively contemplating rulemaking.
Great. Thank you. Appreciate it.
So these were all very good, thought-provoking questions. Thank you so much for asking them. And you still have a chance to ask questions. Feel free to send them to hra@cms.hhs.gov, and we may be able to cover them during this afternoon's breakout session or respond via email. So please join me in thanking Lindsay, Bonnie, Matt, and Kevin for the presentation. So we're going to take a quick networking break for the next 15 minutes, and we'll get started with our next panel discussion at around 11 o'clock. And I'll add, if you need assistance locating the restrooms, just grab one of our CMS volunteers in the back of the room, and we'll get you squared away. So thank you all very much.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.